Today I'm going to speak to you about a very common problem and a lesser known option, treatment option for a very common problem. So I'll give you an illustrative case example of a 36-year-old male who has been hypertensive for 4 years, and he's been investigated extensively for secondary causes of hypertension and they have been ruled out. He's on multiple drugs and still his hypertension has not been under control. And he presented to the ER with a hypertensive crisis with a very high blood pressure, and his renal functions were normal, and all his investigations for secondary causes of hypertension have been ruled out. Similarly, there was another 35-year-old female who presented to the ER with hypertensive urgency on optimal antihypertensives with adequate drug compliance with a very high blood pressure. And this is a 54-year-old male who presented with accelerated hypertension of 210 by 100. He was a post-PCI patient for triple vessel disease. He was also compliant with drugs, and yet the blood pressure was not under control, and all of them were on 4 or more drugs, each one of them. So what next for these patients? What are the options for these patients? You've given them 4 drugs, 5 drugs, 6 drugs, yet the hypertension is not controlled. There is this concept called renal denervation. This concept emanates from the understanding that there's a significant brain-kidney axis which controls the sympathetic nervous system, and the afferent as well as the efferent renal nerves play an important role in the circulating catecholamines, in increase in the production of renin, and in the initiation, sustaining, and perpetuation of blood pressure. If you look at the distribution of renal nerves, the distribution of renal nerves is non-uniform, and as it comes more distally near the pelvis, the renal nerves become closer in closer proximity to the renal vessels, and they are denser as they come closer. But of course, before we go ahead, and so because of this understanding, a concept of renal denervation has been postulated and it has been tested, and the hypothesis had given very encouraging results in initial experiments. So by targeting the renal nerves and by ablating them by radio frequency energy, it is possible for us to break this brain-kidney sympathetic axis and therefore control the blood pressure. Of course, before we do that, we need to rule out some of the renal artery abnormalities. If you look at the Thai Hypertension Society has given guidelines that patients with refractory hypertension. What do you mean by refractory hypertension? Refractory hypertension is a patient whose blood pressure is not under control despite being on 5 or more antihypertensive drugs. And all patients with refractory hypertension need to be offered renal denervation as a viable treatment option, and this class of recommendation has been put at class 1. And patients with resistant hypertension, these are patients who have 4 or more drugs and blood pressure may or may not be under control, also should be offered renal denervation. The European Society of Cardiology consensus statement also recommends that it should be used in all adult patients with uncontrolled hypertension, uncontrolled resistant hypertension, which is defined as a hypertension which is not under control despite being on 3 or more antihypertensive medications, one of which has to be a diuretic with a preserved renal function. So what are the steps for renal denervation? We initially prepared the patient for renal denervation. It is typically done by placing the renal denervation ablation catheter in the renal arteries. So because it's a painful procedure, we need to administer adequate pain medication 5 to 10 minutes before the procedure. And all renal arteries that are external to the renal parenchyma, which are 3 millimeters and upwards, should be targeted for ablation. And patients obviously are anticoagulated, and we can give nitroglycerin to prevent spasm of the renal artery. So the plan starts with doing a renal angiogram. We usually do a non-selective iodogram at the level of the renal arteries, and we need to define the complete nephrogram of both the kidneys to identify all the renal arteries, including the accessory renal arteries, because 30% of patients have accessory renal arteries, and by missing out the accessory renal arteries, we miss out complete renal denervation. So this is the Medtronic Spyral Symplicity catheter, which is used and is approved by the FDA, the US FDA, and it's a user-friendly catheter, and it's a self-regulating console, which will regulate the temperature, and based on the impedance, the temperature and the power are regulated, and so this is how we do an iodogram. We identify the complete nephrogram. You can see that there are accessory renal artery on the left side, and this is how the spiral catheter is introduced into each of the renal arteries, and we ablate at different levels. We start distally. We need to ablate all arteries at 3 millimeters or more, which are outside the renal parenchyma. We do not ablate within the renal parenchyma, but we ablate every renal artery which is at least 3 millimeters in diameter outside the renal parenchyma, and we do it on both the sides, and we make sure that we do not miss the accessory renal arteries. That's why it's very important to completely see the nephrogram phase of both the kidneys so as to identify even the accessory renal arteries. So this way we target most of the branches, and all the arteries which are outside the renal parenchyma are targeted in this fashion. And the catheter is pulled back, and barring the first 2 to 3 millimeters of the ostium, the entire renal artery is ablated. Because of the unique design of the spiral catheter, it gives a three-dimensional longitudinal coverage of the ablation lesions, which gets very effective complete renal denervation.